Okay, what do you think? Shall we just start, Supriya, and then?
Yeah, sure, perfect.
And then I'll admit people so you don't have to worry.
Thank you so much. So hello everyone, and I'm pretty much happy and excited to see you all today. This is our third session on the Respect and Shame in Healthcare and Bioethics workshop series, which is jointly organized by myself. I'm Supriya Subramani. I'm a postdoctoral fellow at the University of Biomedical Ethics and History of Medicine at University of Zurich, and Professor Luna Dolzel, Associate Professor in Philosophy and Medical Humanities at University of Exeter. And this project, this workshop series is funded by Wellcome Trust Shame and Medicine Project. So in this workshop series, what we aim to critically discuss is engage with the conceptual and phenomenological understandings of disrespect, respect, shame, and humiliation, and of course, related concepts. And by bringing together scholars from different disciplines and frameworks, we hope to enhance our understanding of both respect and shame for optimal delivery of healthcare, as well as bring rich insights to the bioethics debates. So just a bit of housekeeping before we get started. The workshop will be recorded and a copy of it will be available afterwards on the Shame and Medicine Project website, as well as we'll send the link towards and also put it on YouTube too. The format of this session is first, the speaker will give presentation of a working paper or the talk for 40 minutes, and then it'll be followed by a discussion for 20 minutes. And then there will be a 10 minutes break. And then we have a second speaker who will give a presentation for 30 to 40 minutes. And then the feedback will be given by the panel discussant. Here, Thomas will be giving to Vanessa. And then there'll be an open discussion. So, and if you have any questions, please use a chat box or just raise a hand, of course, that emoji. Or you can just even type it or you can type whatever the question, I can also read it out loud too. On the final note, we are happy that there will be a special section in the Journal for Evaluation of Clinical Practice, which is it's a special issue edition. And we have opened the call for submissions. So if you're working around these concepts, we look forward to your submissions. So today is the first speaker, Thomas Gutmann. He is a philosopher and lawyer and currently professor of civil law, philosophy of law, and medical law, and a director of the Research Institute for Philosophy of Law at the University of Münster. And his main fields of interest are legal theory, practical philosophy, and theory of society, private law and medical law, and ethics within medical ethics debates. I'm really happy and I'm glad to introduce Thomas Gutmann. I mean, I know him since many years, since 2015, and I'm really happy that he's here with us today, and I'm really looking forward to his talk. Over to you, Thomas.
I'm still muted. Thank you so much, Supriya. I'm going to share my monitor first. So, okay. Can you see my files? Yes?
Yep.
Yes, wonderful. Okay, good. So, as I already told you, my talk shall be considerably shorter than the time allotted to me would allow, because we should have more time to debate and we should put Vanessa's text on center stage today. This workshop series aims to deepen the conceptual, the philosophical, and the phenomenological understanding of respect and disrespect, shame, humiliation, non-recognition, and related concepts in medicine. And my talk will focus on the possibilities and a bit at the end, of course, on the limits of ensuring respect for patients by legal means. The leading hypothesis of the workshop is that a dominant understanding a dominant understanding of respect in the context of bioethics has focused on autonomy, philosophically staying mainly in an Kantian tradition. And the main hypothesis of this workshop, I think, is that a concept of respect in this tradition does not suffice. I think this hypothesis is obviously correct. Nevertheless, I'd like to show that law, making use of the very understanding of respect, which focuses on autonomy and focuses on the mutual recognition of autonomous persons, can effectively guarantee a lot and maybe much more than you think. I will take German law as an example, not to make some advertising for the wonderful legal system of Germany, but because I know it well. I just wrote a 900-page book on these matters, and I do think that we have quite a new law, 8 years old, the Patients' Rights Act, and I do think that this Patients' Rights Act is a serious effort to deal with the questions of respect and disrespect, humiliation, recognition and non-recognition in the physician-patient relationship with the means of law. So I think in German law, I'm going to show you there are quite a number of principles, of norms, of doctrines, aiming not only to guarantee patient autonomy, but also respect, recognition, and epistemic justice within the patient-physician relationship, and aiming at protecting patients from being disrespected, humiliated, or treated as mere means for the end of their own health or even for the interest of others. And of course, I'd like to discuss with you afterwards. I expect there are phenomena indicating a lack of recognition for patients the law cannot adequately deal with. And this will point us to the question of the cultural environment of legal norms and, of course, to the limits of juridification. So, the starting point in Germany, of course, is always the Constitution. There's Article 1 of the German Basic Law saying human dignity shall be inviolable. Human dignity understood as a constitutive principle of the legal system. Yeah? To respect and to protect human dignity shall be the duty of all state authority. There, our civil rights section in the Constitution begins. And Article 2 says in its paragraph 1 that every person shall have the right to free development of his or her personality, and every person shall have the right to life and to physical integrity. And on the European level, looking at the European Charter and the European looking at the European standard of human rights, the European Court of Justice regularly speaks of a fundamental right to human dignity and integrity, and of a right to human integrity, which encompasses, in the context of medicine and biology, the free and informed consent of the patients. This is the starting point. So what are we doing with this? The German Parliament, in giving its opinion to the Patients' Rights Act of 2013, wrote that the main idea of the legislation is that the patient must not be reduced to a mere object, not even be reduced to a mere object in his or her own medical treatment. He or she must know exactly what he or she consents to, must be treated as a self-responsible subject, eine Rechtsperson, a legal person, capable of deciding for himself or herself. So this is presented as the guiding principle. And yes, treatment is just a contract seen from a lawyer's perspective. Nothing special with that, but even a simple contract can express one significant and one special dimension of the Hegelian notion of recognition. And this a particular pattern of recognition which is called legal recognition in Axel Honneth's analysis of Hegel, is a form of recognition which respects the other party as an equal, as somebody formally equal, if different in any practical use, and as a legal person capable of following her own conception of the good and of raising accepted claims. That's what Hegel calls the form of recognition in abstract law, to use a philosophical language. Okay. So the German Constitutional Court 40 years ago said that the institution of informed consent is a direct derivation of the patient's right to self-determination and her dignity. It's rooted directly in the Constitution, and of two most important paragraphs of articles of the Constitution, human dignity and right to freedom of personal development. The patient must be able to decide about his or her treatment as a self-responsible subject. So it's all about autonomy. It's all about the Kantian notion of non-humiliation. It's all about legal rights. It's all about, yes, the atomistic individual, let's call it. But nevertheless, so this is the starting point. The German Constitutional Court said in another ruling in 2005 that the patient's claim to be informed about diagnostic findings and his or her diagnosis is an expression also of her right to self-determination and her dignity as a person. Both principles forbid to assign the patient the role of a mere object in a medical treatment. So this very simple duty of the physician to tell you that you have cancer and not withholding it from you and deciding paternalistically to say, well, I, the physician, decided it may be better for you to have 2 or 3 good months before you die. You don't really have to know what you do, which was the usual way of treating people also in Germany 20 or 25 years ago. Still remember my grandmother's diagnosis of cancer. Nobody would tell her until I did. This quite simple, from a legal point of view, quite simple duty, nothing special with it, is associated with the highest principle of the German Constitution. Yeah? It's denigration, it is a violation of human dignity not to tell a patient, in the right way, of course, that the diagnosis, even of very bad or very severe, very serious diagnosis. So the Constitution is always in the room, if you want, if patients and physicians interact. So it's a German way of thinking about it. It's just one model, but I try to explain this model. This legal principle is extremely anti-paternalistic. I had a big procedure at the German Constitutional Court in the 1990s where I tried to get a leading case, get famous by getting a leading case for an anti-paternalistic understanding of basic rights in the German Constitution, and I failed. I produced the last big ruling, which was quite pro-paternalism. So, but it had some impact. 3 years later, things changed. And in a dramatic ruling 10 years ago, dealing with somebody who was in the closed ward in a psychiatric asylum because he tried to kill his wife and his daughter while being in a psychosis, while suffering from psychosis. The Constitutional Court made clear that all basic rights guaranteed by the German Constitution, every form of constitutionally protected liberty rights, include the right to make use of one's liberty in a way which, in the eyes of others or even in the eyes of the rights bearer himself or herself, is detrimental to the right bearer's well understood interests. The patient's personal freedom is not limited by what physicians deem necessary or advisable. There is a right to illness. Quite a strange thing to say, I think, still by a constitutional court, but I think it does bring the point home. So, and of course, antipaternalism is a kind of respect. I was to, oh no, I'm missing one. What file is missing? I see. The Constitutional Court also made clear that the fact that patients are vulnerable does produce duties to protect, does produce duties to care on the side of physicians and the nursing staff, but it does not diminish the right of the patient to make his or her own decisions, and it does and must not diminish the respect a patient can claim for his ability to make his own decisions. Sorry, I skipped that file. Another thing, and I will come back to this point after Vanessa's presentation, is that there is a very strong general presumption in German law that at least adult persons, and it's changing for minors these years as well, that adult persons are legally competent to give and refuse consent to treatment, other proven otherwise. And this is an important thing because this predicate to be autonomous enough, competent, to have the capacity and therefore the competence to decide for oneself is a very powerful element within the social practices in which statutes, entitlements, immunities, liberties, and the like are attributed, withheld, and contested, as Joel Anderson put it a couple of years ago. In an autonomy-oriented society like ours, classification or being classified as incompetent or as still not competent enough to be allowed to make your own decisions means fundamental exclusion. And by contrast, having the license to make use of your rights must be the default position for adults. In a regime with liberal characteristics, or showing this kind of, well, let's call it liberal respect for people I'm talking about, full decision-making authority and full decision-making responsibility is accorded on the basis of meeting a low threshold of competence. And it is only through such a low threshold concept of autonomy that the fundamentally egalitarian, as well as the inclusive character of the concept or the regime of autonomy can be ensured. So it's clear from the start that not everybody will maximize her or his well-being that way. The low threshold requirement, however, is necessary for reasons of equality, because a system of individual rights has to be inclusive. It has to apply to, well, at least almost every adult person. In order to achieve normative inclusion, in order to achieve normative equality, the ontic status of autonomy as a right, having the right to self-determination and the authority to use them, must include at least most adults, ascribing rights to persons, where the liberty rights or rights to democratic participation has to be an extremely inclusive concept. And in this perspective, autonomy has to define a default position. It is the very sense of ascribing rights within a liberal society based on rights, or in a notion of morality based on equal respect, for this to be as general a concept as possible. Otherwise, it would be impossible to treat persons as equals or with equal concern and respect, to quote Ronald Dworkin. This is what I call the dialectics of protection and tutelage. Protecting people from making wrong choices by invalidating their choices is incompatible with recognizing them as equals. And I think this might be one point to discuss with Vanessa today. But as well, if needed, from the perspective of law, patients have a right to support, they have a right to be supported in a right to being as far as it is possible to be enabled to make their own decision if their competence is in question. And I think in Germany, and not only in Germany, we're taking paragraph 3 of Article 12 of the Convention of the Rights of Persons with Disabilities quite serious these days. States parties shall take appropriate measures to provide access by persons with disabilities, including non-competent persons, to the support they may require in exercising their legal capacity. So if there's any chance to help somebody to be able to make his or her own choices, there is a duty to do so. I think this is really a fundamental change in the legal culture, in the German legal culture, and I guess not only in the German legal culture we are facing these days. There are information rights, which I think are a sign of respect for person. The basic right to self-determination and recognition of one's dignity includes the patient's rights to full access of his or her medical records, which was not the case 30 years ago, where you wouldn't be given any access to your medical records, especially not in psychotherapy or psychiatry. So having the means, having the right to at least to control what has been done with you and to you, is definitely one form of basic respect, of empowerment, which is one form of protecting you from being humiliated, from being treated as inferior, from not being taken seriously, giving you control over the interaction, things like that, by very simple legal means. The right to decide who knows what about you is heavily protected. Throughout Europe, maybe a little bit stronger even in Germany, where it's protected also by criminal law, not only by data protection law. This right to privacy when it comes to medical data, the right to informational self-determination, as we call it, and the constitutional system in Germany. And which is maybe even more interesting for within the framework of our workshop is that I do think that the law acts against certain forms of epistemic injustice in the physician-patient relationship. And I think it does address, well, the discussion has been very fine-grained these days. It does address two of the main forms of what we could call epistemic injustice. It acts against testimonial injustice, the unfairness related to trusting someone's word, to allow somebody to speak for himself or herself, to be heard in what he or she has to say on the one hand, and hermeneutical injustice, the failure to understand someone's unique experiences adequately. So to start with, the German Patient Rights Act explicitly requires the physician and the patient to cooperate in order to achieve shared decision-making in a genuine partnership, as it is called. A partnership based on clear legal rules and clear legal forms of empowerment. I don't think that anything can be gained by replacing systems of rights by systems of trust. I think that clear legal boundaries are essential to enable relationships of trust between patients and physicians. To be a little bit more explicit, in the German law, in the German Patient Rights Act, the physician has a duty to keep the patient informed about everything relevant for the treatment, not only when it comes to obtain the patient's consent for anything, but independent of that. The physician has a duty to inform the patient in an understandable way, seen from the perspective of the patient. His medical competency, his lingual abilities, his intellectual or her intellectual abilities, the information, every kind of information has to be tailored to the patient's horizon and capacities. And we're dealing with these duties in courts these days in a very fine-grained way. There is a duty by the physician to learn about the patient's value system, his decision or her decision environment, and risk evaluation in the process of obtaining informed consent. Yeah. You have to know what is really important for this patient, not for the typical patient, but for this patient in order to be able to obtain informed consent. Yeah. There's a duty of the physician to ascertain the patient's experience of his or her physical and mental situation and living conditions. Yeah. So you have to take the patient's own experiences seriously. You have to try to understand the concept a patient uses to describe his or her experiences, yeah? Because you have the legal duty to understand them. You have to answer every question the patient asks to your best knowledge if you're a physician or a treatment provider of any other kind, which makes a difference. Yeah? You have to give answer. And in the end too, which is new in the German law, you have to inform the patient without being asked about possible malpractice and errors in treatment. If you see any facts hinting at that, whether it was your own malpractice or the error in treatment made by a colleague. So I do think that questions of epistemic justice, a question of respect, recognition, and the prevention of humiliation associated with the cognitive dimension, the epistemic dimension, can be addressed by legal means quite well. And of course, from a standpoint of sociology, we know that legal rules don't apply in practice for 100%. But I do think, and this will be my last point, that defining legal expectations for treatment providers and physicians does transform everyday practice in hospitals. This is our experience in Germany. And we're in this business for 129 years now, starting with the first real basic ruling by a Supreme Court in Germany. At the side, so to say, we did invent, or the Constitutional Court did invent, special basic rights for special kinds of patients or people. There is a right to find and realize your gender identity, your sense of self when it comes to gender, and to be legally recognized in this identity, yeah? Without, of course, having to undergo any surgical procedures if you don't want to, and the right to have them if you do want them. I'm just giving an expert opinion in Germany about transgender kids, where this understanding of basic rights is really important. And in a landmark decision we had last year, which is one of the decisions you get every 10 years or so, we had a decision on the constitutionally protected right to die in Germany, which is now one of the, I would say, strongest constitutional guarantees we have. Yeah? Ending a 300-year discussion with a very clear principle. Interesting, of course, and this is not only typical for Germany, but we did understand it. Now, it took a little bit longer in Germany, I think, than in other jurisdictions that, or legal systems. Article 12, para 2 of the Convention of the Rights of Persons with Disabilities, saying that legal system have to recognize that persons with disabilities enjoy legal capacity on an equal basis with others in all aspects of life. Yeah. If you're incompetent, your legal agency will never be on a real equal basis with competent persons, because there will always be duties to protect and duties to care, not only duties to respect. But whereas 20 years ago, it was very clear that disregarding the will of a non-fully autonomous person, of a non-competent person, wouldn't pose a problem at all. It would even be called paternalism, following Feinberg or Beecham. It's very clear that even a non-competent person, a minor person suffering from dementia, suffering from severe disability, has to have say in what's done to him or her. So what we call natural will in Germany, which is not a very lucky wording, the will of a person which is not competent to be allowed to make her own decisions, has to be taken into account. And the norms about involuntary civil commitment today, after a series of Supreme Court and Constitutional Court rulings, especially about whether patients are ordered to undergo treatment in hospital, are respect-oriented in Germany. They can't be understood as welfare-oriented only. There are procedural safeguards. In the end, you need a court decision for every form of involuntary civil commitment. There are strong duties to explain the treatment to the non-competent patient, and we have about 6 or 7 Supreme Court rulings just around this duty these days. There is a duty to really try to obtain the non-competent patient's assent, which from a philosophical point of view, well, the philosopher in me would give a different answer than the lawyer. As a lawyer, I'm happy with it. And there are very strong precautions by the principle of proportionality. So involuntary civil commitment is always the very last resort to be done. So there is a kind of respect for the legal personhood of non-competent persons. Not only a duty to maximize or protect their welfare, this might be the case too, but a duty to respect them as right bearers and persons, although for reasons of our duty to protect them, they cannot have the last word in what has to be done for them or with them. Good. And yeah, looking at the US, I think I should mention that, of course, a functional social security system guaranteed by law a functioning or at least generally functioning public health insurance for everybody, or almost everybody, guaranteeing a basic level of economic power to every patient, making patients economically less dependent in the physician-patient relationship has a bearing on relationships of respect or humiliation or taking people seriously. This makes a difference. And my last point would be, well, I do legal sociology, just teaching a course. And as I already said, well, that's the law. That's the law in the books, maybe. Yeah. Does it change everyday practices? Yeah. Is there any bearing of it? And the answer is, of course, well, not imminently, and maybe not even directly, but in the long run, even in the middle run, it does. I do think, even comparing physician-patient relationships in Germany to, let's say, France, maybe, or Italy, don't know that much about Great Britain. I do think that we can speak about something like a legally induced culture of respect and partnership in the patient-physician relationship. The legal framework does change cultural attitudes. It does change practices. It does change mutual expectations. Yeah? Not always, not everywhere, not imminently, but it does. So my last question would be, I guess that much of what you call, Supriya, I think, not only microaggressions, but micro humiliations and things like that are still occurring. But I do think they will occur less in a framework where the law does what it can do, using a concept of autonomy-related respect, and looking how far can we come in doing so. Yeah. Good. Thank you very much.
Thank you, Thomas, for that talk. It's really interesting, and I think really interesting to reflect directly on the themes of the workshop and also some of Supriya's previous work and current work. So we have some time for discussion. So I'll open it up to the floor. I don't know, Supriya, do you want to respond to anything since it was directly engaging with you?
Yeah, thank you, Thomas. And thank you, Luna, for just giving me the space quickly before, moving on to other questions. Talking about whether law, the way I conceive the idea of micro inequities, even when there is a law, people, when there is an engagement of micro inequities, right, or the microaggressions, they can't go to law no. So it functions like, I can't even take, I can't ask a doctor, why are you not seeing me eye to eye? If it happens again and again and again, and it's like a pattern, it keeps happening, but then I can't go to the law for that. But then there's another way around when the law is much more stringent. For example, I could give an Indian context. There is a Caste Discrimination Act, where is untouchability, or like Atrocities Act, which is like on Dalits, like lower caste group, when there is a law which clearly says the upper caste should not even use certain labeling, stigmatizing words. But then what they do is the upper caste or the privileged group of people, they don't use those labeling words, but they use a different kind of subtle interactions, replacing that need not be a caste, but use a class or in a subtle ways of, still targeting that group. So then the law just makes it as you said, on the paper, but in practice, whether the society is ready. So as you were talking about the legally induced culture, right? To bring a change, can it push forward to make a respectful culture, whether law can push for a respectful culture, or should the society, I know it's a challenge, it's a debate, I understand, but whether society should be ready to accept a certain law. For example, you said Patients' Rights Act is 2013 in Germany. I'm wondering what happened from 1800s till this, because there's I remember when you did mention about the German Act, long time 1990s aspect, and why did it take such a huge time? Is it more about the society was not ready? I mean, do you think that way, or yeah, I'm just bouncing my idea. Sorry.
Well, first point is, of course, yes, of course, there are a lot of micro inequalities the law cannot deal with. Yes. I tried to put it the other way around. If the law tries to deal with the general relationship of respect, then I guess in the long run, micro inequalities will get less and less. That's what I say. On the other hand, maybe I'm living in a sort of paradise, but also inequalities in wealth get bigger in Germany 4 times as quick as they do in France or Denmark or anyone else in Europe. So we have a very, very bad dynamics when it comes to this. We certainly have to do something about this, because we all know that equal societies are more healthy societies. Also, we really have a real problem. Germany, in our cultural perception, in our practices, isn't much of a class society. I think not as equal as the Scandinavian ones or maybe the Dutch, but still on equal footing. So many things you see in India or analyzed in India, you don't see them that much in German hospitals. I think, yeah, so there are no elites treating the lower caste as a general picture for German hospitals. Yeah? I think the people are treating, there's a mutual agreement on being equal, which is settled in many practices. I don't want to play down the problems. Yeah? Of course, it's an expert layman's relationship going to the physician. Yeah? But then again, it's the law that says, well, with differences come duties. Duties to enable, duties to inform, duties to take seriously. Yeah? So, in the end, I really do think that, yeah, the legal framework has the power to change life world practices. At least up to a point where it's bearable, I would say. So, and that's something.
Thank you.
Any other questions or comments? Very good.
Well, I have lots actually, but I guess I suppose one of the things is around how, because I like what you say about the law kind of setting a sort of a framework of standards that people hopefully will move towards, and you know, it having a longer term impact upon behavior rather than a sort of an immediate change. I suppose I'm wondering about whether what might be done in terms of positive discrimination rather than sort of equal treatment. So, for example, I'm in Ireland, and we have a community of what are called travellers, and if that term's familiar to you, and you know, their health status is very poor. Their life expectancy is terrible. So half of them are dead by the age of 39. Only 3% survive to the age of 65. So there are lots of social and access issues. And so I suppose I'm interested in how we can positively, I suppose, improve the status of individuals rather than necessarily not providing barriers.
Yeah. Well, I think that's the weak point in the German approach, because we neither have a culture of public health as strong as the British and the Irish do, nor the societal institutions to do it. We, of course, have the same problems. My wife is working with kids of these subgroups, which we have in Germany too. We are not very good in this. We're not really reaching them. We're not really addressing them. Yeah. There is still major health inequality in Germany. So if you look at the lower third of income and the upper one, male persons in the upper third have a life expectancy 11 years younger than male persons in the lower third of the lower economic stratum. So yeah, we could do better. We're very good in protecting a conscious notion of respect. We're not that good in, well, these people have decent social security. But as you made clear, the problem are laying elsewhere and have to be addressed in a different way. I would say when I work with colleagues from the UK or Ireland, it starts with the universities. So people in the medical faculties with the job to analyze social factors of health and reaching out to these people. Yeah? I know so many people, so many professors in British universities doing like that. There is none in Germany. No one else. We don't do these kind of things. And this is clearly a failure. Yes. And if we want to say so, again, it's a collective form of disrespect because we know who pays the price. Yeah. So there's, yeah, I can't make it any better. That's the way it is. Yeah. We're not good at that.
I don't think any of us are very good at it at all.
Yeah. They are seen as still as a nuisance, you know, coming from Romania and Hungary within the European Union, you know, the discussions, things like that. And there's another problem associated with this extremely legal framework of informed consent. You have to be able to speak the language to give informed consent. So what are we doing with our high standards and high standards? Yeah, of course, the physician has, legally speaking, has the duty to get an interpreter. We got that. It's the physician's duty, not the patient's duty. It's a step to the right direction, but it doesn't suffice. How can you? There's high standards for informed consent, which are a form of respect for persons, mean that if you won't get treatment if you don't speak my language well enough. So that's another problem.
Yeah, for sure.
Thank you. Any other questions, comments? Paul, go ahead.
Hi, Tom. Thank you very much for your paper. Really fascinating. And I'm curious, when you talk about the treatment relationship being just a contract in those terms, what happens when in the contract there's almost a third party at play, which is the public health requirement? And I'm thinking particularly about the person living with HIV. who may well they certainly have a duty in the UK not to transmit their illness, their virus, which can only happen in a contractual relationship. But the person who lives with HIV doesn't have any more responsibility in not transmitting his or her virus to the other party. Law says that person who lives with the virus does. But I'm curious as to whether that person who lives with the illness therefore has a duty to comply with his or her clinician to take medication to prevent the transmission. And if that patient who is living with the virus and doesn't take the medication somehow is a lesser biopolitical player, somehow they're reduced, their life becomes less grievable, that they have fewer rights, and in fact we move into a sort of Mbembe's idea of necropolitics, that these people who are not taking medication and who may transmit are somehow actually really risky to the whole of society. And there's something really interesting in what happens in their legal right to refuse treatment.
Yeah. Well, you know, we had a famous politician in Germany whose answer to HIV in 1980, it was 1984 really, was let's build concentration camps again. That's what we're good at in Germany, you know. After the craziness of the 80s, all these irrational fears of society about HIV, well, are gone. I think maybe we err on the wrong side. So we wouldn't say there is a legal duty to take your medicine if you're HIV positive. We cannot force you. If you don't want to do it, you don't do it. The question is, are we even allowed to warn your potential sexual partners? And the discussion is unresolved. Not very good. And the only thing we have concerns a married couple, where the husband was HIV positive and didn't tell his wife. And both were patients of the same physician. The other court said, well, the physician's duty to protect. Oh, sorry. Can you hear me again? Okay. I had problems with the net. The court said the physician's duty to protect the wife is the stronger duty than protecting the privacy of the HIV positive husband. So again, this is a sort of evaluation which you could underwrite, I think. This is still a very liberal approach, I think. So the moral duty to protect others, maybe even protect yourself, if you're HIV positive, wouldn't transform into a legal duty in Germany. Which again means, of course, there will be no public health approach in this case. So,
thank you. I think that's a really interesting response, because I guess in the UK, no person living with HIV would wish. Well, I mean, one would hope that they wouldn't deliberately set out to transmit their virus to a third party. But I think that there is a framing that happens that says, you know, certainly since post-1996 and the advent of new antiretroviral therapy, why wouldn't you take the medication to reduce your viral load to being untransmittable? And therefore, you are no public health risk. And so the autonomy of the individual to choose not to take medication, while you say, of course, is perfectly free, the agent is perfectly free to make that choice. My contention is that within the biomedical discourse, they're not free to make that choice, that the microaggressions that occur to say that the overwhelming public health requirement says that that person's individual right to choose is foregone for the sake of the wider society, for the benefit, the greater public benefit outweighs the autonomy of the individual. And in that case, then the whole idea that there's a contracts can't be negotiated because one party's already at a disadvantage.
Yes.
They have already actually contaminated themselves in a way, in a shaming act that says you no longer actually have the right to negotiate. And I think it's that when you see it through that lens, you go, whoa, well, that's something quite different.
Yes, it is. Yes, it is.
It's 2 o'clock right now, so perhaps we should pause here and just take a short break, and then we are going to come back for Vanessa's talk. So yeah, I'm looking at our timetable, right? Break from 2 to 2:10. So shall we just take 5 to 10 minutes and come back at 2:10, and then we'll kick off with Vanessa?
Okay.
Great. See you then. Thomas, there's a question in the chat from Chris. I don't know if you can see the chat.
I just opened it. Thank you. So.
It's clear.
Hi.
Shall we start again, Supriya? Yeah. Okay.
Hi, sure. Shall I just introduce Vanessa? Yeah. So welcome again for the second half. And today we have early careers research scholar, Vanessa Di Luca, is a postdoctoral fellow in philosophy at University de Rennes. She's also an associate investigator at the Interdisciplinary Laboratory of the International School for Advanced Studies in Trieste. Her research interests lie at the intersection of moral psychology, normative ethics, cognitive science, and clinical practices. And from a methodological perspective, her work confronts directly with some of the challenges raising from the attempt of hybridizing theoretical humanistic methods of analysis with data-driven methods. So over to you, Vanessa. I'll not take much of your time, and please take, I think we have good enough time and we can also discuss much more, thank you. Over to you.
Thank you. Thank you so much for having me today for this Respect and Shame Healthcare in Bioethics workshop meeting. Thank you to you, the organizers, for your support, and a special thanks to Professor Gutmann, who was very kind reading my presentation, and even on a very short notice. I'm going to share my screen. Okay, so I think you can only see it. So I want to start by giving you a bit of orientation of what I'm going to discuss today. So I'm going to present the theoretical framework and the research design of a study that I'm developing jointly at the Department of Philosophy of the University of Rennes and at the Interdisciplinary Laboratory at the International Schools for Advanced Studies in Trieste, in Italy. And the study focuses on the general representation of addiction disorder in the public, at the public level, and it seeks to investigate how these representations relate to our moral judgments toward addicted people, and also to investigate the sort of reactive practices we have as a society and as individuals towards addiction. So judgments of moral responsibility are particularly central to understand the sorts of practices, of reactive practices we have towards addiction. By reactive practices, I refer here to practices such as shaming, sanctioning, blaming addicted individuals for their actions. And those judgments may also have a range of different consequences, practical consequences, from how drug policies are conceived and formed to how professionals in the healthcare and criminal justice systems behave toward addicted individuals. Our primary goal in this study, in this research, is not to engage really with the discussion of what specific descriptive or epistemic hypothesis about addiction is correct and we should adopt, though I will engage in a discussion with the most important and impactful models of addiction that we are currently adopting. But really to call attention to the normative dimension of this phenomenon and provide the framework to assess and possibly reshape unfair or unjust reactive practices towards addiction and addicted individuals. So more specifically, I'm going to discuss, well, I'm going to briefly introduce the research project in which this study situates. It is part of a larger project we are developing. I will then introduce very briefly some of what I think are the typical responses to addiction. And I will most specifically focus on what I define the compassionate response towards addiction, and showing how this sort of stance toward addicted people is really related to a model of addiction that has become, as I was saying, a sort of default model in addiction research and also at the public level, which is the brain disease model of addiction. I will then assess some of the studies which take issue with the practical consequences of labeling addiction a disease. And I will then present the core question, the experimental design, and some expected result of our studies. So as I was saying, the study I'm presenting today is part of a larger project called REACT, which is a project about reactive practices. As I was saying, those are the practices in which we engage in the face of wrongness, such as punishment, blame, shame, or forgiveness. And our aim in this project is to address some normative, theoretical, and empirical questions about these practices, with a specific focus on their normative distortion associated with discrimination. The notion of reactive practices, we designed this notion to vindicate the social, practical, and institutional dimension of our judgments of attribution of moral responsibility. So in a sense, it is really somehow an expansion of the Stroessonian notion of reactive attitudes that has received great attention in philosophical discussion, the philosophical literature about moral responsibility. And we point at the conceptual connection as well as the impact of these practices in shaping our autonomous agency, but also on concept as diverse as the concept of mutual respect, how they impact on our practices of inclusion, of empowerment. And a key question of the project is how reactive practices such as, for example, blaming and stigmatizing can affect clinically impaired individuals, agents, and how we can detect this sort of distortion and address them, for example, by nurturing more constructive responses. So a first branch of the project is a legal branch that I'm not discussing. It focuses on the relationship, the interplay between punitive and non-punitive responses we can have towards crime. And the second branch, which is the branch I'm focusing on today, is a study of addiction, as I was saying, in light of our reactive practices. And it involves interactions of our team with a professional in the domain of therapeutical treatment of addiction and professional in the domain of law, such as magistrate and judicial training professional, who will also constitute our sample, our population, for an empirical exploration of the belief of those targeted group with respect to different models of addiction, to see how these beliefs shape their conception of moral responsibility of addicted people, and eventually also affect their clinical strategies or might influence legal action in criminal cases involving addiction. So addiction is clearly a very complex phenomenon. And the idea of what sorts of responses, normative responses and normative practices are appropriate toward it have changed a lot through times and with scientific development. So I think we can identify three main responses that are connected to different representation of addiction and that involve different sorts of judgments about the moral responsibility of addicted individuals. The first one is a retributivist response that as individual and as a society we can have towards addiction. It is basically the view that addiction is voluntary choice for which subjects are morally responsible. And on this view, addicted subjects are also responsible for what they do under the influence of substances. So they are responsible for becoming addicts and they are responsible for what they do under this condition. According to the retributivist response, moral and legal responses such as blaming and sanctioning addicted people are justified and are also morally appropriate responses, since addicted people are responsible for what they do. But then there is a sort of different, slightly different response that we can have toward addiction. And I call this a mitigated response. This is a view that holds that addiction is a middle ground behavior between non-voluntary and voluntary behavior. And this middle ground involves excusing condition for addicted behaviors. So in this model, in this view, moral and legal responses such as blaming and sanctioning can be justified, but mitigating factors should always be considered to make these responses morally appropriate. Finally, there is the response in which I'm mostly interested. There is what I call the compassionate response. And this holds that addiction is a disease and that addicted subjects have no voluntary control over their action. Though in this case, moral and legal responses might be, again, justified, they are never morally appropriate and should be actually replaced completely by a sort of different stance toward addiction. There is a forward-looking stance, a forward-looking response that aims at the care, recovery, and rehabilitation, inclusion, social inclusion of these individuals. So as I was saying, I am interested in this response that in the addiction literature and debates has been standardly associated with the neuroscientific developments leading to the formulation of the brain disease model of addiction. And this is an extremely important model that has gathered a lot of support from the scientific community. It's endorsed by all major bodies like the World Health Organization, the National Health Institute in the US, the European Institute for Health, the OECD, etc. It is also the model that currently shape the healthcare and criminal justice system practices. It has been widely shared at the public level through public discourses, campaign, etc. So this model defines addiction, as I said, as a disease, as a chronic, relapsing neurobiological disease characterized by compulsive use despite negative consequences. And this shows that addiction is caused by long-term biological and functional modification of the brain, and specifically of the brain system involved in reward, pleasure-seeking, motivation, and decision-making. As supporters of this model often say, the addiction basically hijacks these brain systems and compromise their function. So the brain disease model offers an explanation for a behavior that it's been for a long time puzzling and considered irrational. And it offers this explanation in a quite simple and parsimonious way. So put it simply, it says that addiction engender compulsive behavior as a result of a physiopathological dynamic that is completely independent of the subject will, meaning that addicted in people are not free to choose anymore whether to perform or not the specific behavior which is the object of their addictions. They basically literally do not have any alternative possibility or a possibility to do otherwise, and they are just compelled to do what they do. So in a retributivist conception of responsibility, if people do not have the possibility to act otherwise, which is the classical definition of free will, then they are not morally responsible, since free will is a basic requirement for the attribution of moral responsibility. They're not responsible, and they are not even blameworthy for their action, since blame is the appropriate moral response for voluntary wrongful actions. So by locating the causes of the addiction in the brain, the model reduces the free will and therefore the moral responsibility of addicted people, and shift somehow the reactive response from the sort of retributivist response traditionally associated to what has been defined a moralized view of addiction, a view that attributes responsibility and blame to people for this choice, to the sort of compassionate response associated to a medicalized understanding of it. And note that this double role of the brain disease model, the fact that it takes into account both epistemological, theoretical aspects of addiction that are in line with scientific, neuroscientific developments, and practical implication, strategical implication, is considered a great virtue of this model. And indeed, when Alan Leshner and other scientists introduced this model in the mid-90s, it was very clear that part of the motivation was the idea that by reducing the attribution of moral responsibility and blame, the model would have been somehow constitute an important political and public tool to reduce stigma towards addicted individuals and indicate a more compassionate, humane approach to this condition, at least as worthy public health objectives. And actually, the stigma attached to addiction is something quite pervasive, and it has very serious consequences, harmful consequences for addicted people at different levels and scales. At the social level, it has been seen that the stigma towards addiction reinforces the perception that as weak-willed or vicious people that act against shared social norms, these people deserve social punishment, which might be expressed in the form of hurtful label, hostile feelings, rejection, isolation, ostracism. There is also an institutional aspect of the stigma towards addicted people, which concern healthcare providers or legal professionals' attitude that it has been seen might be affected by this sort of stigmatizing attitude toward addicted individuals, and may avoid engaging with them, with addicted clients, keeping them at the risk of further harm. And finally, at the personal level, self-stigma, of course, is related to feeling of self-shame, self-hate, feeling of being unworthy of help or recovery, that leads addicted subjects to conceal their condition and preventing them from seeking treatment. Here you can say like a campaign that try to tackle these sorts of stigma related to addiction by making explicit reference to the disease model, in which it's emphasized the fact that addiction is not a choice. And despite the popularity of this model, the truth is that a few decades on, there have been studies, a lot of studies that have questioned both the epistemological, theoretical soundness of the disease model and its practical strategic effects. A first trend of objection to the brain disease model questions the plausibility of the idea of compulsion in addicted behavior. And this line of critique is based on evidence showing that compulsion or compulsive use is simply a bad way of defining addictive behavior because it's false. The evidence for this kind of argument comes in particular from the results of studies with people on treatment called contingency management treatment, which are treatment that basically motivates and sustain abstinence by offering a choice to people between drug consumption and a certain kind of good or positive reward, which might be voucher or free tickets to go to the cinema, a short amount, a small amount of money, etc. So what this, the results of these studies show is that voluntary behavior and contingency responsive choices really figures quite centrally in addiction. But so if choice figures in addiction, then there is no more point in talking of compulsive use, no matter how strong and difficult to overcome are the desires connected to addiction. The underlying question beyond this critique, I think, concern really the nature of addiction and whether addiction is itself a disease, or more specifically, a neurobiological disease that implies that sorts of consequences, such as the loss of voluntary control. And I think it is important to stress that scholars are still divided on this issue. Different theoretical and epistemological options are available. There are scholars who reject the disease label altogether, and others who point to different ways of talking of disease or disorder in the case of addiction that do not imply the concept of compulsion. Some researchers have come to develop models of addiction as a disease of choice, for example, or as a disease or motivation, a cognitive disease. All these concepts nuance the idea that addiction have, to a certain extent, some control over their action, although it can be seriously impaired. But the second strand of objection to the disease model concerns the practical and strategic aspect of it. And so the consequences of labeling addiction a disease, the fact that we can now provide a biogenetic explanation for this condition, has produced the sort of shifting in attitude that we might have expected from it. And the studies address some very interesting, I think, and important question, whether this shift has been just something real or assumed, whether the brain disease model really helped to reduce the blame associated with addiction, and if so, which particular information about the brain disease model is most likely to have such an impact on the judgment, public judgments towards addiction. And to sum up the findings of these studies, that have engaged with this question, research have found that on one end, biogenetic labels or disease labels can have actually positive effect on lay conception of mental disorders and mental disease. So if the disease, it has been seen that when the disease is deemed biological, people may actually view sufferers of the disease as less responsible for having the disease, thereby blaming and stigmatizing the sufferer to a lesser extent. And of course, that can be an incredibly healing thing for people suffering from this condition and for their relationship, the relationship with their social environment. But on the other hand, and in spite of what we think might be the consequences of this label, the idea that biological information reduces the attribution of free will and thus diminishes moral responsibility and affects our tendency to attach certain type of stigma, particularly the blame-related stigma that goes with the retributivist response. These consequences remain contested, with several studies reporting actually quite the contrary. So some researchers have shown that the disease label in the case of addiction might even increase stigma towards addicted individuals. In a study of 2011, Angermeyer found, for example, that belief in biogenetic labels are often related to a greater stigmatization because of the perception that biological disorders and illness are unchangeable or uncontrollable. And the authors of the study found their result to be fairly consistent with Wehner's attribution theory. A core assumption of this theory is that the controllability of a certain behavior and a stigmatized behavior is consequential for perceived responsibility, which in turn is consequential for the kind of social emotions and outcomes that we might have in response to these behaviors, such as, for example, helping behavior. And on this perspective, the uncontrollable nature of biogenetic cause of behavior can actually be a source of fear and stigma that induce rejection. This result suggests that the disease model of addiction might end up having limited effect with respect to the stigma towards addicted people, and it might end up evoking a sort of stigma and marginalization as much, if not even more, than the moralized conception of addiction, because it simply moves the prejudice and the condemnation to other levels. And in order to make progress in solving this question, this issue, neuroethics researcher Eric Racine and his colleague in 2017 undertook a large psychological study to test people's representation of addiction when they were exposed or not to the sort of information about the brain disease model of addiction. And they tested whether neuroscientific information actually diminish attribution of free will in the context of addiction, and whether other respondent characteristics, such as gender, education, knowledge of neuroscience, problem with substance use, or knowing people that have a problem with substance use, influence actually the attribution of free will and modulate the effect of neuroscience information. And at the end of the study, which considered the question of responsibility in its multiple facets, Racine's team finally comes to the conclusion that this favorable impact that we have attributed to the brain disease model in shifting our attitudes towards addicted people and the stigma, consequential stigma, has been exaggerated. This conclusion is found on the fact and the findings that ultimately only a combination of textual information and neuroimaging slightly mitigate the voluntary aspect of cocaine addiction. But neuroscientific information alone, or even presenting people neuroimaging, was absolutely not sufficient in producing the kind of shift in the understanding of addiction and the associated response. And furthermore, they found out that other characteristics, such as education, the knowledge, the self-reported knowledge of neuroscience, were actually great factors in decreasing the attribution of responsibility and blame, much more than the neuroscientific information alone. So, I think I have 5 minutes more. I just want to underline another important implication concerning personal stigma, and in particular the idea that there is of great importance in healthcare and treatment programs, that biological views of addiction would facilitate the uptake of treatment, because individuals who no longer are considered at fault for that problem would more easily access medical treatments. But it has been seen that stressing the biological nature of addiction has not necessarily been found to encourage treatment. it could actually lead to fatalistic belief that may undercut the motivation to follow treatment, or even undercut the belief that people are able to control and to comply with the treatment for their condition. On the contrary, the belief in free will and related belief in self-control and responsibility could support attitudes and behavior associated with seeking and complying with treatments for addiction. So, in a very real sense, the disease label is really a double-edged sword, and whether it is a good thing or a bad thing depends in part on who the audience is, who's taking up this label, and what are the kind of belief and representation of these people. Like Racine, we believe that the destigmatization of addiction cannot be pursued by simply adopting a certain description of addiction, and that the practical endeavors of the brain disease model can be pursued in a different way. In this respect, we think that the question of the representation and judgment about addiction is crucial and deserves to be investigated. And in particular, we would like to push Racine's research hypothesis further by asking the following question. If the radical conception of addiction and addictive disease, of addiction as a disease, such as the one conveyed by the brain disease model, do not really have a positive impact on the destigmatization of addicts, what kind of consequences would a more flexible conception of pathology compatible with a certain form of agency, which might correspond more to the idea that we have of the addictive condition, can have on the sort of response we can have towards addiction. And I don't know if I'm allowed other time. Actually, I haven't seen at what time I've started, so it's if it's done with my time, I will stop here and just go straightly to the conclusion.
I think you have a couple more minutes, Vanessa. So, yeah.
Thank you so much. Thanks. So to develop this question and to try to understand what kind of impact the recognition of a certain sort of agency to addicted individual might have on our responses to this condition, we look at the therapeutical and legal context where practitioners face actually the question of addicts' agency and responsibility in different and complex ways. Think about engaging people agency and responsibility for pursuing actually a therapeutical path, or holding them accountable for wrongdoing and wrong action. So I have, in the therapeutical and legal context, people usually have no problem recognizing this sort of agency to addicted individual for different objectives, of course. But we want to test actually the sort of aptitudes and representation of addiction this specific population has, in order to test whether this recognition of a limited choice in addiction is compatible with maintaining respect, concern, care, and compassion as practices that might finally play a central role in the process of recovery, rehabilitation, and prevention of crimes. And to do so, we will conduct a national multicentric study involving different geographic areas of France. We will recruit 100 participants from these two targeted populations, health professional and legal expert. We will conduct a first study that will be a multidimensional analysis of a questionnaire and a focus group targeting the belief and attitudes of the participant towards about the determinants and causes of addiction, the agential competences of addicted individual, the degree of responsibility attributed for their conduct. And then a second study will test the possibility to manipulate their judgment through textual information that will frame addiction in a more fine-grained terms. So we will frame addiction as a disease, like in the case of Racine's study involving some sort of defectiveness. And we will frame addiction as a choice, implying some share of agency, for example, performing certain action to satisfy addiction, to be somehow able to recognize yourself as an agent performing those actions. And we will then ask the participant to complete a short questionnaire about what sorts of practices they deem adequate or justified, such as stigma, blame, punishment, shame, help, healing, trust, or forgiveness. And afterwards, the participants exposed to this small manipulation would also be asked to repeat the same questionnaire. So we will carry out this analysis through by constructing a validated questionnaire with reference to a validated questionnaire called Addiction Belief Inventory. We will conduct a focus group in order to clarify some of the questions, of the problematic questions, that will arise from the questionnaire. As I said, we will use textual information to manipulate judgment based on different understanding and conception of addiction, and we will develop a questionnaire about reactive practices. So yeah, this is the addiction belief inventory, but I think if someone is interested, I can leave this for discussion. I'm just quickly concluding by saying that the project has really a practical aim. So based on our results, our wish is to develop some practical tools for practical intervention, both in the context, in the legal context and in the therapeutical context, that might help putting under the right attention the sorts of attitude we have towards addiction, and which kind of treatments could facilitate the sort of non-stigmatized attitude we want to achieve. I will also leave this for discussion if you are interested. And I think I'm really out of time, so I'm stopping here. Thank you so much for listening to me.
Brilliant. Thank you, Vanessa. I think I'll hand it over to Thomas to give some comments and feedback, and then we can have a general discussion and questions.
Yeah, thank you. Again, will be short because I think the discussion between us all will be the important thing. Thank you very much, Vanessa. So, who am I to criticize your study design? So, I have a basic education in social sciences, and I think that this is an excellent project and very sound. I don't have any internal critique. I have some external critique or questions about it. For the study itself, I think the aim, the methodology, the hypotheses are very clear and very promises and extremely plausible to me. So leave it like that. So I'm just not competent to do much more fine-grained critique. The interesting thing for a philosopher like me is that, well, I think this is experimental psychology. So psychology observes it's a fact-based science, of course. You lose complex concepts, of course, but it's observation. It's not a normative discipline. And this makes it interesting because I could say, so while in the end, I think this is very valuable to know what you're looking for. I could make it easy for me to say as a philosopher, do you really know what you're talking about? Yeah, I'm not completely serious now. Because you apply normative concepts, but you don't analyze them. You have an observer's perspective, not a participant's perspective, which is necessary for a normative discourse, for the weighing of normative arguments. I give you an example. Your central aim, you said, this is a normative aim, is to look, how can we produce a shift to more positive reactive responses? How can we produce a shift to responses which helps us to empower the individuals who are in the grip of addiction? Nothing wrong with that, but that doesn't answer the question. If you would talk about, not about addicts, but about rapists, or people who do sexually abuse very small babies, you wouldn't say, my central aim is to produce the shift to a more positive reactive response to those people and to empower them to face the situation and to destigmatize them. And of course, an observation of the stigmatization of rapists would show, I think, very, very similar results. Stigmatization has bad effects. The interesting question is, should it have bad effects? Shouldn't we stigmatize them? So the first normative question would be, should we stigmatize addicts? And of course, this is, I think, the philosophical question about the attribution of responsibility is completely independent from everything you can do in your study with the methodology you apply. Which is not to say that you're doing something wrong. It's just to say you're doing something different from an ethical analysis or a philosophical analysis. So should we hold addicts responsible? I think the whole Aristotelian tradition, ethics, would say, and part of legal institutions still have the same question. Well, maybe I cannot hold a person in an addict or in a situation of craving responsible for what she or he does in the situation. But what stops me to make him or hold him responsible for all the decision he or she made before she became an addict? And then, of course, we have a second question. Really, can we hold addicts responsible for the decisions they made? They brought them into the addiction. Or are there other normatively mitigating factors? Yeah, I had a bad childhood. I had a trauma with my mother. I had an accident. I was discriminated against. Something like that. Is it possible to hold people responsible for addiction, obesity, things like that? This is a normative question. You cannot answer them. And so you just assume what you can, what you don't and cannot discuss with the methodology. Of course, you could discuss it as a participant in an ethical discourse. We could do that, but you don't do it. You just, there seems to be let's say, a normative void in the middle of your project, or you're floating on a normative assumptions you cannot control with the methodology you're applying. So you could say, I wouldn't, in the end, I think I would agree with you. If we had a normative discourse now, I think chances are good that we would end on the same page. But this discourse wasn't presented by you. And for example, in this philosophical discussion about addiction, we might ask, well, at least when it comes to shooting up heroin or cocaine, especially these days, or meth, one thing we have to say is what's so bad about addiction is that you're financing criminal cartels who got so powerful these days, they're really threatening our states. If you look at Belgium and the Netherlands, for example, what do you look? So being an addict might be extremely socially harmful, way beyond questions of health. So maybe we have, in the end, I think we don't, but it's an open question whether we have very good reasons to stigmatize certain kinds of addicts. And maybe there are good reasons to hold certain kinds of addicts responsible for at least some of the choices they made. Seems to be an open question. Yeah, we would hold rapists responsible for what they do in 98% of all cases, without questioning that. And yes, of course, there's a difference between rapists and addicts, maybe a crucial one. So, yeah, the research is about manipulating judgments about addiction, which in the end I would say is a good thing. And could be normatively justified if you really try to do that, but you didn't do it. The question of how to change reactive practices, and this is certainly from a philosophical standpoint, reactive practices is a very good concept to work with. Yeah, much better than straws. It's wonderful. Like that very much. The question is, should we? In which way should we alter our practices? Maybe they're justified, or maybe our central aim could be to produce a shift into quite another direction, things like that. So I'm only making one point. The normative analysis can't be replaced by an empirical one. And my question is, do you have these philosophical, ethical, normative discussions in your project, or are these assumptions just treated as givens within your research group?
Well, thank you very much for your comments. It's extremely rich, and I'm happy to reflect more thoroughly on your questions, which points to what I would say are methodological and also meta-philosophical reasonable doubts. And I understand that, the sorts of dialogue between disciplines that we try to create in this project, but that is more and more common, even in philosophy, to test some assumptions and belief of people in order to discuss normative hypotheses, theoretical hypotheses. It's an enterprise that it's puzzling in a certain sort of way. But we side with the authors that are undertaking this sort of project of hybridizing the philosophical methods and put at test some philosophical hypotheses by using the methods of other disciplines, such as the analysis of belief common people, lay people have about certain normative hypotheses, since a lot of normative theorizing is finally based on some descriptive claim or assumption, no? About who people are, what they believe, or what's the most common opinion about certain sort of things. So the idea is very much to put at test this assumption that sometimes the normative theoretical approach is doing. So I'd like to see the thing also the other way around and explain the needs of doing this sort of analysis about normative assumption in the context of the attribution of moral responsibility, and the attribution of moral responsibility in a specific case of such as addiction is particularly relevant because it can inform better, no, the sort of normative analysis we are then able to produce, I think. So we really see the more normative branch of the project, which is in charge of doing the sort of analysis, normative analysis of the concepts that are at issue. And so also the very concept of reactive practices we are designed and its relationship to the attribution of moral responsibility is one of the goals of the project, to analyze this sort of connection, which we do not give for granted anyway. But maybe there is something that I wasn't able to convey about the project. I don't know if this responds to some of your worries, but I mean, I think there is a lack of importance accorded to normative questions and ethical questions in addiction researches. We wanted to really address this gap. We think that addiction researchers, and most of all, the medical therapeutical practices that are shaped on the most common model of addiction, do not take into account normative questions about addiction, underestimate completely the sort of responses, practices we have developed towards this phenomenon. And in the case of therapeutical treatment, addict subjects themselves develop towards themselves, and then can really affect the practical efficacy of certain treatments that we are assuming works better than other in addiction, in treatment, given the acceptance of a certain model of addiction. We think that the project, I think, really addressed this lack of fine-grained analysis on concepts such as responsibility, blame, stigma, because what we have found and what other researchers have found studying the researches that have been developed under the brain disease model, mostly by neuroscientists, and working on this issue, is the quite, naive use sometimes they do of this very concept. And they completely lose sight of all level of description of addiction, and they lose sight on the normative implication of this level of description of addiction. So that's what we wanted to point out by stressing, but with our critique to the brain disease model, and stressing the necessity of really studying people's belief about this conception. What we expect is that, as other researchers have found, that differently from other sorts of disease, a lot of practitioners in the field of law and in the field of addiction treatment accept the idea that addiction is a disease that implies that implies the loss of voluntary control, but still have retain a lot of the responses that are typical of a this, let's say, more moralized view of addiction. That's what the sort of this how to say, the sort of incoherency, let's say, epistemological incoherency that we see at play in addiction is that this disease label is, and the whole epistemological universe that comes with this framework is not supported by people belief, by people, not, I mean, lay people, but more specifically, because that's what we are interested in, people working with addicted subjects that are supposed to cure them or evaluate their actions. And this is still different from what addicts think about themselves. They see themselves, they take sometimes this disease label, no, as a tools for healing shame, etc. But again, if you analyze their conception about themselves, their moral responsibility and attribution of blame, you standardly see that these people recognize their responsibility. So there is a clash at different levels and scales, which might, we think, compromise certain practices, because at least for what you discussed, for example, no, the relationship between practitioners, medical practitioners and patients. I mean, if we just disagree, so I mean, clearly on what the disease is, what it implies in behavioral terms, and in terms of moral judgment, the sort of therapeutical path and can be really compromised. So that's what we want to show, I think, and that's the practical aim of the study, is to really train practitioners to have a less naive conception of addiction in the first place, and more awareness about the discrepancies that are at play around this concept that might affect their practices. And finally, and I understand, I see your doubts here, why working on these beliefs should also change attitudes of practitioners. Well, I don't know. I mean, I think recognizing agency and responsibility in this specific case for addicted individuals can be an empowering tool. Because really the sort of therapeutical treatment that we, and also the goal of sanctioning these people is really to create some sort of self-change, some sort of rehabilitation, and these goals can only be achieved by recognizing some sort of agency to the individual, not by denying it. These are outcomes that the subject can really undertake only when he or she recognizes or attributes to herself or himself some sort of agential competences, not encouraging him towards the belief that he has a disease that, as I have just very quickly said, might nourish certain fatalistic attitude, which is exactly the contrary of self-change and self-progress.
Okay, I think we don't disagree. It is for me very clear that the strength of your approach is that you are reflecting so many levels and meta levels about what you're doing. But I still would claim that whatever you explained in your statement right now again makes clear that you never reach one level which is and maybe should be out of the scope of your approach. The question, how should we treat addicts? The normative question. You never reach that, and you cannot reach that. But the interesting point, of course, is also the other way around, because of course we philosophers have blind spots of our own. And one of our blind spots would be that I think for regardless which meta-ethics you choose, almost regardless. It is clear that normative reasoning has to look at certain sorts of facts, which is self-evident for a normative philosopher who's trained in the good Anglo-Saxon consequentialist or utilitarian tradition. It's a little bit harder for a Kantian like me, but even people like me understand the facts. And there are moral arguments who almost supervene on psychological or biological facts. So fact-orientated research very often has to change normative arguments. But I think there's, for us philosophers, there's still a bigger problem we can learn from you. We would say that almost regardless of the kind of meta-ethics we find adequate, there's a big consensus that if a behavior is induced by a brain disease, cannot be controlled, you cannot act otherwise, or what all the alternative formulation we devised as philosophers for not able, the old Frankfurt saying, not able to act otherwise, then you cannot attribute responsibility. And now I learned from you, okay, Thomas, that may be right in philosophy, but our reactive practices showing our really reactive attitudes in real life situation prove otherwise. We do, in our practices, attribute responsibility regardless of what you in your ivory towers think should be done or should not be done. And this is tough for an armchair philosopher to learn. Yeah? Because, well, yeah, whatever you do in practical philosophy, at one point or the other, you have to look at our real practices. You can start with them, you can end with them. You can give them more weight or give them less weight, but you have to look at them. And if the practices tell us otherwise, then theory, we have a problem Rawls discussed 50 years ago. Theory versus, well, consider judgment or long-standing practices. So you show me a blind spot. The really interesting part is epistemology. Yeah? So what can I think interdisciplinarity is never simple. It's always extremely complicated and indirect. Yeah? So there is mostly no. If we look at this, if you as a psychologist, I call you now reflective, experimental psychologist, and I a theoretical, practical philosopher, we look at the same spot. We have to see different things because there is in academia nothing which is not constructed differently from different perspectives. So the interaction is interesting, and it's never easy. It's never direct. So it's no bad thing that you can't ask, you cannot answer my normative questions directly, because you're a psychologist, and of course I being a lawyer or a philosopher, I cannot answer your empirical questions. I would have to join your team to do so. Okay. So this is really, so I would say the relative weaknesses of our standpoint. This is the interesting thing in what we're talking right now.
Well, if I'm allowed a short response, I have the sort of dilemma, like epistemological and methodological dilemma myself, because I am trained as a philosopher, and then I joined this neuroscience, cognitive science team that used completely different tools, and I had really to ask myself how I could interact with these people, because for me it was a completely different way of analyzing problems. And so I I mean, the ambition of the project in itself, as I conceived it, was to put into psychological analysis the sort of normative richness that, as a philosopher, you can have, and so to really see how normative questions are, yes, a matter of theory, but can also really practically shape people's psychology and have effect on the way they conceive of the world and vice versa. And so it's not that I see the two enterprises completely distinct. And that's in this sense that I somehow join with those philosophers that are now labeling themselves experimental philosophers, especially in the field of world psychology. There is this attempt to do this sort of analysis. But I mean, I see that the sort of richness you can have with a philosophical analysis goes somehow lost. And I thank you also for showing me that maybe the normative statements of this project of promises that we are somehow giving are out of reach. I mean, they might have been overstated. And that maybe the project can contribute to sort of normative aim in a different sort, not showing us how addicts should be treated, which remains an irreducibly probably normative questions, but just I mean, giving the sort of psychological insight that this kind of normative question, that this kind of are partially constituted of. And it's to prove that by manipulating this sort of psychological aspects, belief and responses, we can have normative changing. So the onus of the proof is pretty much on the experimental philosopher.
Yeah, I think in the end, you can tell me about the manipulability of reactive attitudes, where in practical philosophy we would be looking for reasons, which is quite a different thing. But I think on the other way, so I'm tough here, and I'm old school. At the end of the day, there is no such thing as experimental practical philosophy. Okay. There isn't. That's just a misuse of concepts. But what I would say is, what I think from my perspective makes your project so strong is, and that's why you need philosophers in projects like these. If you conceptualize a research project like this, you make sure that its results are important for very, very different and have a high importance for different normative approaches. Mm-hmm. Yeah, so it's valuable and rich, and will be quoted very often by philosophers working in the field, or ethicists by working in the field, because the design makes it open, and I'm missing an English word now, compatible with very different approaches. So and whatever normative argument you wanna run, you have to deal with this kind of research. And although there is no direct way from empirical findings to normative arguments, research like this does produce, let's say, points which cannot be, which have to be included into an adequate normative argument of the field. So this makes it really strong, I think. So that's what I meant is, you cannot really do what you claim to do, but you're still doing more that you're expected to do.
That's a kind way to put it. Thank you so much. Thanks. Really, I really enjoyed your comments, and hope, I mean, the reply were like adequate, or at least clarified some of the points that that this complex sort of approaches bring with them. Yeah, I will be happy to discuss some of the results when I will have them, since, I mean, I hope this talk today was about the results and not just the methods. It would have been interesting, but then we got so much delayed, and we still are just working on our data, and that I think it would offer also another perspective. Now, when you have the data and you really can work on explanatory hypotheses. I mean, as a philosopher, you have a lot of job to do in that case, starting from the data to the possible explanation you can make about them. And I would have enjoyed to do this with you today, but well, that will be for another time, I hope.
I would say if you know first what we really should do, then it would be wonderful to know how to produce the results the way we want to have them. What I'm really looking for. I will come back very, very often to your approach, because I happen to be quite sure what I know in some medical fields, and yeah, no, really good. Thank you very much.
No, thanks to you, really.
So we still have a bit of time if we want to open it up, if anyone, yeah, Paul, go ahead.
Thank you, Vanessa. Thank you very much for your paper, and thank you for that fascinating conversation and discussion with Thomas. And I say this as somebody who's in recovery, so I kind of speak as an life experienced person in this. And I guess that following Thomas's questions about the normative questions, I want to ask about the normative assumptions, because right at the heart of it, you talk about causes for addiction, even Thomas's phrase of saying becoming an addict. And as somebody who was an addict, I think there's a really interesting question that I spent a lot of time in forensic archaeology trying to understand why it was that I am the way that I am. When I get myself out of the way and say, it is just as it is, and I don't have to find the cause, and I have to just notice the consequence, the outcome, the being present to what is, then it becomes a little easier to find a way through all of that. So I just invite you to think about the language that's used around saying there's always a cause. We have a very strong belief. What I know today is that I may have a belief about something, and my belief is almost never right. My experience always is. There's a very interesting thought. When I recognize that my belief is wrong, but my experience is right, then something different happens. And right at the heart, curiously, of the 12-step program, there are many other ways of finding recovery, but is the paradox of step one, which is that until I accept my powerlessness over my addiction, I will never recover. Because until the point I accept within the 12-step framework, and as I said, there are lots of other ways of finding recovery, if I don't recognize my powerlessness, which of course has to set aside my agency, my whole idea of free will, my whole idea of being in the world, that I have the competence and ability to change what's happening, it's the very heart of why people are addicted, because they can't live with the feeling of how they are in the world. So they take a substance, they do something that changes the way they feel to be in the world, and then they're an addict. But I think really the interesting question that in relation to shame that comes to this, and I was really sitting listening to it, especially with the provocation that Thomas gave about rapists. If I'm a sex addict and I rape people, where's the interesting moral responsibility there? And I think the really curious question is about the stigma scale, if I want to put it in those terms, of which substance is more problematic than another. So the cocaine addict is likely to be looked down on by the person who's addicted to alcohol. And the person who's addicted to alcohol might look up to the person who's addicted to weed. So, it really, I always say in my own recovery journey, it doesn't matter what my substance of choice was, whether my substance of choice happened to be alcohol, but it could easily have been anything else. And is the person who's addicted to gambling somehow less morally culpable? Is alcohol more acceptable because it's legal? I think it asks, nobody asks those questions. Mm-hmm. But I think the point about addiction is that the substance of choice is irrelevant. And actually in the journey of recovery, at the beginning of a journey of recovery, mm-hmm. saying that mine was not a moral problem, but one of health is very helpful. Then there becomes the question of, can I become well? And who judges whether I'm well or not? Then we might be back to the agency question. So anyway, they're just observations, but I really was fascinated by the discussion.
No, thank you so much. I mean, you raised a whole bunch of researches and reflections about addiction that I haven't touched upon, but that are extremely, extremely interesting and fascinating, as you said. Like the first thing you said, the personal experience and the point of view of addicted individuals on their own addiction. This is a central element, according to me. I mean, there is this line of studies and researches called that really focus on the phenomenology of addiction, because addiction is a person level condition, that concern people, agents, individuals, and so there is a whole phenomenology about it that unfortunately, I think. The relevance of this sort of question goes completely lost when you use a certain framework for defining addiction, which is unfortunately the framework that we are currently agreeing upon as a society, at least, in our public health choices. We are deciding to go along with a model that I think completely cut all these sorts of phenomenological elements from its view of addiction, what it is as a phenomenon, and what are the most effective strategies in order to prevent and heal addiction. And it also cuts all the different nuances about the substance of choice in case of substance addiction and drug addiction, so-called drug addiction. I mean, the behavioral is still something different. But I want to make a general point that concern both the importance of recognizing that there is a different attitudes toward people using cocaine or people using cannabis, and there is a still different attitudes toward behavioral addiction, so gambling or sexual addiction. Again, there are a lot of studies about that which confirm your hypothesis. Yes, I mean, there is a completely different, I mean, I think that the concept of behavioral addiction has really changed our way of conceiving addiction. And it's been probably the most important, I haven't cited it, but I think it's really the most important argument against the brain disease model. Because if you go into the details of the brain disease model, you see that a lot of importance is attributed to the substance. It becomes really a problem of the relationship of the subject with the substance and the effect of the substance on the brain. When I say it, I mean the addiction eject the brain. The real definition, to make it simple, that it's commonly used in this discussion is the substance ejects the brain. So there is really this pharmacological view. And most of the people, the researchers in addiction studies are commonly pharmacologists. I mean, because a lot of importance and it's been accorded to this part of the addiction, and maybe rightly so, because there are evidence that there are real changes in the brain if these changes are pathological, that's more questionable. But the concept of behavioral addiction, which does not include evidently, this sort of level, has completely changed our way of thinking about addiction. And it's more and more common to think of addiction on a continuum with some sort of normal behavior that can, of course, reach certain level of certain difference without common desire, but there is some sort of continuity and which do not involve any substance or any chemical effects of substances on the brain. Then you can say, well, but also strong desires have chemical effects on the brain. So a strong desire to play also can affect the brain. Yes, but you can say so of most of the desires people have. Normally, they affect the brain. Yeah, actually, there is all this learning perspective that basically says so. I'm not going into details because I'm not even so confident with this literature, but this is an argument against the fact that we might put a special division between normal and pathological behavior in the case of addiction by underlying all this sort of continuity. And this again, I mean, it's the reason why we want to question the brain disease model of addiction. And I think, the 12-step that you mentioned, the approach, which is proved very effective, especially for the treatment of certain addictions like alcohol addiction. I think it was born as in that community of addicted people, that you have to recognize powerlessness over addiction. As I said, there is evidence that I believe that what is most healing in recognizing yourself as a diseased person in the case of addiction is exactly that sort of relief from agency and responsibility you might find tough to have. And so I understand also, this point in common with this other approach to addiction that is much more complex anyway than the brain disease model, which is the 12-step approach. But again, there are a lot of questions around this strategy and the methods of this strategy. And for example, the centrality it attributes to the community and to the fact that you. I don't know that very well to give you a full reply of where to situate precisely this point. But I think that on the other hand, working on the agency of these people and working on their sense of moral responsibility for what they do without attributing necessarily the stigma that traditionally has gone with the attribution of moral responsibility might be a sort of more effective way of treating this sort of condition. I'm very much aligned here to what Anna Picard there has developed as a model of responsibility without blame for practitioners, because as she says and frame it, the recognition of agency in this case is pay much more in the long-term strategy than any other sort of strategy that has been developed towards addiction. And so I also think this is a suggestion that has to be explored much more in the therapeutical approach towards addiction.
Supriya, did you have a question as well?
Yeah, overall, I just had a comment, and it's a follow-up with the Paul's actual, comment, which he said. So it seems like from Vanessa, when you were mentioning about the disease model with a compassionate view, right? I mean, and then the overall conclusion or the larger key takeaway, the way I sensed it, and just correct me if I'm wrong, is like, it seems like is a disease model is only path towards demoralization of the discourse in addiction. I mean, is it something, is there in this literature is something, it's the only path towards demoralization of the addiction, do you think? Or the shift, as even Paul was mentioning, right? It's nothing more towards the source or the cause, but then it's much more towards a recovery. Then the approach should be non-stigmatizing approach for recovery, right? Then the reactive practices would be from the other way around than from the causal point of view. Then the whole question is about who has this responsibility. Should we even talk about the responsibility idea in itself? Because if the social and the biological context both play a role in any addiction, acknowledging that, but then focusing and shifting towards recovery, then the reactive practices should address towards a social context rather than to the individual responsibility, right? I mean, that's just a thought it came in, but yeah, I'm not sure that I make, yeah.
No, I'm not sure I'm able to respond to your comment. I mean, it's a very interesting question, and it's an interesting point of view. From the perspective of recovery, well, I pretty much sit into that perspective actually, and I've also worked with people actually working with addiction and addicted individuals for recovery, and I have pretty much seen the disease label used in this context to facilitate people accessing treatment and also to healing the sort of shame that sometimes can prevent them from accepting or recognizing of having this problem in the first place. Because I mean, the stigma towards addiction is so powerful that really makes people compared to other sort of disease or disorder, a really hard time to even accept that they are that kind of person. And so the disease label is conceived just for this kind of purposes. And it's thought to be effective in terms of the treatment strategy because it facilitates the recognition of the disease and then the access to healthcare treatment. But then when you pursue a strategy, which is tailored on the individual stories, which is made by behavioral or cognitive therapy or more traditional psychological approaches, well, then you have a whole difficulty to reconcile this all semantics even of disease and with the sort of experience people really have. And to point out how they can use certain resources, even their own shame, I mean, which can be, as we know, sometimes under certain conditions, a tool for motivating oneself to self-improve or to inhibit certain kind of behavior. This is very difficult for therapists to do because there is a lack of knowledge and vocabulary of this part of the story with addiction. And so it's important in my view to focus on the agential perspective in the treatment of addiction and the agential resources that this individual might have, and being careful with using the label, because as I was trying to say, I mean, the benefit in really real practical terms, which are in healthcare, the terms of the effectiveness of the treatment, can be can be, I mean, like really a double-edged sword, as I said, and that's the ambivalence I wanted to really address. So I think, I mean, there is a sort of failure to recognize that this opposition, between a disease model or a choice model of addiction as two completely different options to describe addiction and to develop therapeutical strategy of an addiction is a bit like out of focus, I think. Maybe the two perspectives together, which is the reason why I want to emphasize that the practical endeavors that this model has introduced in the debate are really worthwhile to achieve, but the path is still not very clear. I was just reasoning like around your suggestion and
any other questions or comments? Barry, go ahead. You're muted.
Sorry, I'm interested in, there's a lot of focus in this around, I suppose, external sources of stigma, and I'm wondering how weighted they are compared to self-stigma in addicts. That self-stigma is not necessarily because of external valuations or external stigmatization of you as an addict, but rather your shame, the source of your shame is I suppose your personal failures and your the fact that you have lost your partner who no longer wants to live with you, and your children will no longer talk to you, and you've lost your job, and the multiple sort of, I suppose, social sources that reflect on you as a person and are not necessarily related to the fact whether the doctor views you as a lesser being or not.
Yeah. Well, I guess that in thinking about this particular interplay between stigma and shame, how, of course, there is a different dimension of shame. There is a socially induced shame that is produced by external factors, as you were mentioning, and a more internal shame produced by personal values, ideals, and moral standards to which the individual, the agent, take herself to. I've thought a lot about shame in my studies during my PhD. I think these two perspectives quite overlaps. I agree with you that these are different sources of shame, triggers of shame, or reasons for being ashamed for the individuals. But I think there are also important points in which the social aspect of shame, which is pretty much built into the conception of shame. Shame is something that we feel towards other people. There is an intrinsic reference to the gaze of other in shame. So there is something at the core of shame which I think is importantly socially shaped. And so I'm willing to think that social stigma and self-stigma are two related phenomena, and they can affect each other. The sources of self-shame can be connected pretty much to what are the social standards, but not in a sort of, passive or interiorized way. But because we are like socially shaped agents and so very sensitive to social norms that might contribute pretty important to shape our identities. So I have thought about that. So I don't know how to reconcile my perspective of shame, which is pretty in depth of the social perspective about shames and the social sources of this emotion, and the fact that, of course, there is a personal level that might be not connected so strongly with the social environment. But in the case of addiction, since it is such a moralized condition that I have doubts. I mean, I have difficulty to think of a person that is not affected in her own personal judgment by this fact. Personal judgments about addiction from addicted individual, I think, are quite resonate, no, with what's the representation of addiction at the public level. And that's why it's so important to address, no, this certain way of phrasing or conceptualizing addiction at public level, because after all, they really have a great impact on the perspective, judgments, and feelings of people that live and experience this condition. The very way people reflect about their own addiction is quite affected by how the phenomenon is perceived at social level. And so the external sources of stigma can really overlap with the internal one, given the specific nature of human agency, I think, but this is something that you may not agree. And given also the specific nature of the disease that is attracted a lot of social judgments.
Thank you.
Thanks both. I'm just conscious of the time. We have sort of 3 minutes left. Does anyone have any final question or comment before we wrap up? No? Well, we can finish here. Supriya, do you want to say anything to close?
But I'm really happy. I mean, thank you, Luna. And this is excellent. I mean, the way I connect Thomas Gutmann's talk with Vanessa's, I mean, the way I would see it as let's say if respect as a way to acknowledge a person's, recognition, respect, both whether it was addicts or within the larger framework, we need to understand the social and the larger, the social context plays an important role. And recognizing that whether it's through health insurance or the larger insurance system, or whether within the larger healthcare system or within the social context plays an important role. So it's not just within the healthcare settings, but it's the larger role it plays in, but through law, through, of course, to the law, public health systems too. So yeah, I just thought that both connects really well, and we need to acknowledge that.
Yeah, thank you. That's great. Right, well, thank you all for being here, and thank you, Thomas and Vanessa, for your talks and the discussion. It was really rich and really interesting, and just great to hear you both kind of going back and forth. It was really fun. This talk will be recorded and it'll be sent to everyone who signed up for the talk, and you're welcome to share the recording once it's done. We'll send it to you, and also it'll be on our website and stuff. So hopefully the talk will have a life after this session as well. Great, and lovely to see everyone. Thank you for coming.
Thanks a lot.
Thank you very much.
Thank you very much.
Thanks.
Thank you.